invite you for the next talk on complex strabismus forms, but simple solutions. I think that's very important to provide simple solution to every complex situation. Over to you, Dr. Raman.
Okay. Hello. Thank you so much for respected chair and my co-panelists. Thanks for the opportunity. So my talk is based on the muscle transplantation surgery. Usually when we do plan for a concomitant form of strabismus, especially exodeviations and esodeviations, for moderate amount of deviations, so regular dosage works very well. But when it comes for the larger deviations more than 50-60 prism diopters, then there is a need to do muscle on the surgery on the third muscle or the fourth muscle. And as Vivek was telling, so we have a very good option actually in the form of muscle transplantation. So I am going to share my experience with unusual complex situations. Okay. In this procedure, we use the resected muscle piece and transplant it onto the resisting muscle, and that recessed muscle length is increased so that the arc of contact will be maintained very well, and at the same time its functionality is not compromised, and it enhances the recession effect. So here I can show that picture, and I can show the video here. This is a muscle transplant surgery, a snippet video. The lateral lattice muscle is identified here. After hooking it, we use a 5-0 H-band suture to replace the suture onto it, and then I switch on to identify the medial lattice muscle, and usually I do the painting of the muscle surface both at the tendinous insertion point as well at the intended point of resection, and two double-armed vehicle 60 vehicle sutures are used here, and we complete the resection procedure as usual. And once the resection procedure is over, then that resected piece of muscle is transplanted onto the recessing muscle. So here the recessing muscle, already we replaced 5-0 H-band sutures. So that suture is used to suture the resected muscle piece, so that the length is increased, almost like though there is 2 millimeters of shrinkage, but the length is appropriately increased. And in my experience, there are 3 cases where I used a muscle transplantation surgery to how to resolve the clinical dilemma. Here there is a young male, 31-year-old male patient. You can see here right from his early age. At the age of 7 years, there was a thorough orthotropia, and at the age of 27 years, there was a thorough orthotropia. But later on, he started complaining of diplopia on and off. For last 1 year, he has been suffering with double vision, and there is a huge, large deviation of almost like 80 prism diopters. You can see here. So after thorough orthoptic evaluation, we could found that the deviation is around 85 prism diopters, and you can see all the extraocular movements are normal, and added to that he has a paradoxical diplopia. Usually in exodeviation supposed to produce cross diplopia, but here he has uncrossed diplopia, and that is diplopia charting it shows, and then all other parameters are normal, and this case was taken for muscle transplantation surgery. So here I did 11 millimeters of LR recession with 7 millimeters of MR resection with muscle transplantation. So these are the pictures shows here, the intra pictures. And then post-operatively you can notice we achieved orthotropy, and patient was relieved of double vision, and the CSP problem also got relieved. So this was at the end of 1 week, and at the end of 6 months we can see nicely in up to date also he is maintaining the ortho, and there is no complaints of double vision. And here is my second case. This gentleman had the bilateral sixth nerve palsy 10 years back, and later on, 2 years back, again he developed bilateral sixth nerve palsy, and there was a recovery of right eye totally, but in the left eye there was partial recovery. And the peculiarity of this case is that there is a partial recovery with a huge deviation, almost close to 75 prism diopters of deviation, and the limitation of movement is -2 limitation, both in levo version and levo elevation and levo depression. You can notice that the deviation, and here there is a disproportionate amount of recovery and the motility issue. Okay, so this is a peculiar situation. Usually in a lateral rectus palsy, as we discussed earlier, R&R procedure works very well up to 50 prism diopters of deviation, and even modified Nishida is also doing very well. But here the situation is this 75 prism diopters and -2 limitation. Simple R&R is not going to work. So I did a muscle transplantation surgery again. So you can notice here we achieved orthotropy and patient got relieved of double vision. And here my third case is a case of Duane's retraction syndrome in a girl. She is a nurse working at Sholapur. Since birth it was there, and the peculiar feature here is the affected eye is the left eye, but there is a secondary deviation, large secondary EZO deviation in the right eye, that is the contralateral eye, because the right eye vision is poor. There is a compound myopic astigmatism, and add to that strabismic amblyopia is added, so that the deviation is almost 90 prism diopters. So here you can notice here in the left eye there is limitation of movement on all levo positions, and on attempted adduction there is fissure width narrowing, and in the right eye movements are full. So this case again I took up this case for the right eye correction. Okay, in the right eye, because it's such a large deviation, once again I did muscle transplantation surgery for this patient, and it has resulted in almost near orthotropia, almost like residual deviation of 8 to 10 prism diopters was there, but patient was cosmetically very happy. So at the end of the discussion, I think the muscle transplantation surgery can be applied not only in the regular concomitant esotropias and exotropias, heavy eyes and heavy eye syndromes, but in unusual complex situations also it can be utilized. So with this I conclude.
Yeah, thank you, sir. I think wonderful application of the procedure. It is very nice talk, and as you said, it avoids the complications of doing an extra large surgery, and very well applied. Thank you.
Thank you.
Thank you. I think we have just overshot the time by 5 minutes. We will not hold back anyone, but thank you. Thanks to all my co-speakers as well as co-panelists for being here, and thanks to the wonderful team of all the attendees, delegates, for being here in large numbers. It's very heartening to see you all.